Hello everyone. Today we are going to discuss about Hepato-renal syndrome. So HRS was defined as a syndrome that occurred in patients with cirrhosis and portal hypertension and was characterized by the impaired kidney function, defined as a serum creat level of more than 1.5 mg per deciliter in the absence of underlying kidney disease. So basically, this HRS is divided into two types, HRS1 and HRS2. HRS type 1 is characterized by the rapid reduction in the kidney function with increase in the serum creatinine level exceeding 2.5 mg per dl in less than 2 weeks. And HRS2 is the more chronic deterioration in the kidney function. So now we'll see the how the evaluation of the definition of the AKI has happened. In 2012, the new definition of AKI was harmonized with the kidney disease, improving global outcome definition as increase in the serum creatinine level of 0.3 mg per deciliter or higher within the 48 hours, or increase in serum creatinine level that is at least 1.5 times the baseline level and known or presumed to occur within previous 7 days. And in 2015, there is a modification of this definition, that is increase in the serum creatinine that is more than or equal to 0.3 mg per dl within 48 hours, or increase in more than or equal to 1.5 times baseline level, which is known or presumed to occur within previous 7 days. So, and in 2019, there is a absolute, the definition of the AKI was absolute increase in serum creatinine more than or equal to 0.3 mg per dl within 48 hours, or more than or equal to 1.5 times baseline level, or urine output less than 0.5 ml per hour in 6 hours. Now, in 2007, the hepatorenal syndrome defined as cirrhosis with ascites, serum creat level of more than 1.5 mg per dl with no improvement, decrease of less than 1.5 mg per dl after at least 2 days of diuretic withdrawal. Volume expansion and volume expansion with albumin, that is even after giving 1 mg per kg per day or maximum of 100 mg 100 gram per day, and in the absence of shock, no recurrent or recent treatment with the nephrotoxic drug, absence of parenchymal kidney disease as indicated by proteinuria more than 500 mg per day and microhematuria more than 50 red cells per high power field, or abnormal renal finding on ultrasound. As you can see here, the HRS is the diagnosis of exclusion. That means after excluding each and every possibility, still there is a rise in creatinine, which is not explained by anything. Then in the background of cirrhosis and ascites, we can label it as a hepatorenal syndrome. So in 2015, the definition of HRS was similar to 2009, except for the removal of serum creat more than 1.5 mg per day, and the inclusion of AKI diagnosis according to the KDIGO serum creat criteria has included, which is increase in serum creatinine of more than or equal to 0.3 mg per dl within 48 hours, or more than or equal to 1.5 times of baseline. In 2019, the definition of HRS was similar to 2015, except for they have added the urine output criteria, which was less than 0.5 ml per kg per hour for more than 6 hours as a criteria for AKI. And in HRS AKI with the fractional excretion of the sodium less than 0. So, what is HRS type 1? The HRS type 1 is the rapid progressive renal failure defined by the doubling of the initial serum creatinine to the level of more than 2.5 mg per dl in less than 2 weeks. And in HRS acute kidney injury is defined as absolute increase in serum creatinine of more than equal to 0.3 mg per dl within 48 hours, or increase in serum creatinine more than 0.5, more than 1.5 times of the baseline, and the third criteria is urine output of less than 0.5 ml per kg per hour for 6 hours. So it is very clear. So if there is an absolute increase in serum creatinine of more than 0.5 mg per dl within 48 hours, and if there is an increase in serum creatinine more than 1.5 times of baseline, or if urine output is less than 0.5 ml per kg for 6 hours, we can say it is HRA in the background of CLD or NSIDs. So HRS type 2 is defined as when there is a slow progression of the disease. That is, in this, the serum creatinine will increase from 1.5 to 2.5 mg per dl with steady or slow progressive course, and it is typically associated with the refractory ascites. Then HRS CKD criteria is when there is a eGFR falls less than 60 ml per minute per 1.73 centimeter square for more than 3 months in the absence of other structural causes. And HRS acute kidney disease is defined as when eGFR is less than 60 ml per minute per 1.73 for less than or equal to 3 months in the absence of structural cause, or less than 50% increase in serum creatinine with the last outpatient value within previous 3 months baseline level. Now, how are we supposed to assess the response to therapy? If there is a complete response, that is reversal of HRS, a decrease in serum creatinine to less than 1.5 mg per day. If there is a partial response, that is decrease in serum creatinine more than 50% of pre-treatment level without reaching level of less than 1.5 mg per day, and no response is defined as no increase in serum creatinine or decrease to 50% of pre-treatment level with final level more than 1.5 mg per dl. And when we can say it is relapse, then when there is an increase in serum creatinine of more than 1.5 ml after discontinuation of therapy. And when we can say the full response, that is a return of serum creatinine to the level within the zero point 0.5 mg per dl of baseline level. Partial response is defined as regression of AKS stage with the reduction of serum creatinine to more than or equal to 0.3 mg per dl above baseline level, and no response, no regression of AKS. So the patient with cirrhosis, particularly those with ascites, have an increased susceptibility to AKI because of the hemodynamic alteration that results from the portal hypertension. The initial mechanism in the pathogenesis of the portal hypertension is increase in intrahepatic resistance due to distortion of the liver architecture, that is fibrosis and nodules, and increase in intrahepatic vascular tone. Then, because of this high pressure, there will be the activation of the vasodilator in splanchnic circulation to compensate that, which is more important, more important component which is responsible for this vasodilatation is nitric oxide, and it leads to the progressive splanchnic and systemic vasodilatation. So there is an increased translocation of the bacteria and the bacterial product due to intestinal dysbiosis, bacterial overgrowth, and the altered tight junction protein contribute to the further vasodilatation. The resulting in reduction in the effective arterial blood volume that will activate a neurohormonal system, that is a RAS system, which is renin, angiotensin, aldosterone system, sympathetic, and the arginine vasopressin system, which causes the sodium and water retention, and it leads to the ascites formation. In advanced stage of cirrhosis, the progressive vasodilatation leads to the more avid retention of sodium and water, resulting into the refractory ascites and dilutional hyponatremia, respectively. With progressive vasodilatation, the vasoconstricting system, mainly renin and angiotensin, are activated, resulting into the renal vasoconstriction and the decreased renal blood flow. In addition, the relative decrease in the cardiac output in this high output state of the cardiac failure may further contribute to the decreased renal perfusion. The reduced renal blood flow results into the decrease in the GFR and pre-renal type of the kidney injury that does not respond to the volume expansion. Renal vasoconstriction in patient with the cirrhosis is not countered by the release of vasodilatory substance, that is prostaglandin, because of decrease in their production and local release of the vasoconstrictors such as endothelin. So the pathogenesis of the renal vasoconstriction and the decreased renal flow in cirrhosis represents the mechanism that initially leads to ascites. Thus, patients with the cirrhosis who have ascites, particularly those with the refractory ascites, they are at highest risk not only for the development of AKI but also for the most severe clinical form, that is Hepato-renal Syndrome (AK). So it is more commonly precipitated by the factor that causes the decrease in the effective arterial blood volume. And these factors include rapid fluid loss, which can occur with the use of excessive diuresis in the gastrointestinal bleeding, and then worsening vasodilatation vasodilatation, which are induced by the drugs like angiotensin converting enzyme inhibitors and systemic inflammatory response, that is infection. Now, how should we assess the kidney function? The evaluation of the kidney function in patients with the cirrhosis remains critically important and equally challenging. So the serum creatine level, which is the most practical and commonly used marker for the kidney function, and the major used in the model for end-stage renal disease, that is MEL score, to prioritize candidate for the liver transplantation. The which overestimates the GFR in patient with the cirrhosis because of the combination of decreased creatinine production due to liver disease, protein calorie malnourishment, and muscle wasting. In addition, patients with the AKI and the fluid overload and increase in serum creatinine level can lag by several hours or days despite decrease in GFR. So estimated GFR equation based on the serum creatinine, cystatin C, and the both are simple method of determining kidney function in the general population of person with the stable serum creatinine level. So in patient with the cirrhosis, however, eGFR equation tend to overestimate the true GFR by 10 to 20 ml per minute per 1.73 meter square of body surface area, especially in patient with the GFR of less than 40 ml per minute per 1.73 meter square. Ascites or both should be used with caution. The accuracy of the eGFR measurement is important in patient with the cirrhosis because eGFR is one of the factors used to determine the candidacy for simultaneous liver and kidney transplantation. Now, the diagnostic workup and the management of the AKI. Once AKI is diagnosed, it is important to discontinue any medication that could have role in precipitating and the worsening AKI, especially diuretics, vasodilator, non-selective beta blocker, and NSAIDs, and to rule out infection, particularly to spontaneous bacterial peritonitis, which is a frequent precipitant of AKI and the HRS-AKI. The diagnostic workup for the AKI is essential for treating early AKI and the preventing progression. So the cause of AKI determined on the basis of the patient's history, physical examination, urine test, and the response to the diuretic withdrawal and the volume challenge. So the microscopic examination of the urinary sediment is important to rule out intrinsic cause of AKI. Measurement of the fractional expression of the sodium and the urea have been used by the clinician to confirm hypovolemia and HRS-AKI and to rule out acute tubular necrosis. Urinary neutrophil gelatinase associated lipocalcin, a marker of tubular injury, has shown to differentiate between HRS-AKI and acute tubular necrosis. Kidney biopsy should be considered only if the result might change the management. For example, treatment of the glomerular disease. Since the biopsy is the invasive procedure and it may be associated with the bleeding complication. So, what is the central for the treatment of the AKI? It is volume expansion because the cause of AKI is the volume depletion. The response to the volume expansion will help to determine the cause of AKI. The type of resuscitation fluid, that is crystalloid versus albumin, and the amount should be individualized according to the cause of AKI and patient's volume status. So the volume resuscitation is recommended for the trial period of at least for 24 to 48 hours in patients who are clinically hypovolemic or euvolemic. However, it is important to exercise caution in administering fluid in patients with AKI in order to avoid fluid overload in pulmonary. So the assessment of intravascular volume and the volume responsiveness is desirable but has been challenging in case of HRS. Now, the combination of the assessment, including careful history taking, physical examination, then we can take help of the point of care ultrasonography, static dynamic measurements when available should be used to evaluate volume status as well as fluid responsiveness. There is insufficient evidence supporting the use of paracentesis to improve intra-abdominal pressure or theoretically kidney function in patients with the cirrhosis and AKI. Partial ascites removal is recommended for comfort in patient with tense ascites and should be accompanied by intravenous administration of albumin to prevent circulatory dysfunction. A vasodilatory state that follows the large volume paracentesis can lead to worsening kidney function. So this large volume paracentesis means the removal of at least more than 5 liters of the fluid. Now the treatment of the HRS. The mainstay of pharmacological management of HRS-AKI is the use of vasoconstrictor combined with the intravenous albumin. So the change in serum creatinine level correlate inversely with the change in the mean arterial pressure induced by vasoconstrictor. So vasoconstriction have not vasoconstrictors have not been shown to improve survival. So their use should be considered as a bridge to transplantation rather than cure for HRS-AKI. So the terlipressin, it is a vasopressin analog and it is the most common vasoconstrictor used worldwide. Guidelines recommended it as a first-line agent for HRS-AKI. So the terlipressin can be administered intravenously as a bolus or as a continuous infusion with a similar efficacy. However, the cumulative daily dose and the incidence of adverse events are lower with the continuous infusion. Initial dose can be increased, maintained, discontinued according to the response. There are changes in the serum creatinine level. The terlipressin was associated with the increased incidence of respiratory failure due to pulmonary edema. So it is essential to withhold terlipressin and albumin if there is a clinical evidence of intravascular volume overload, that is anasarca, jugular venous distension, hypoxemia, pulmonary congestion, elevated right ventricular systolic pressure on echocardiography. The response to norepinephrine as an alternative vasopressor are similar to those with the terlipressin. However, now norepinephrine requires the continuous infusion in ICU. The combination of the octreotide and the midodrine has a weak vasoconstrictor activity. A randomized control trial showed the combined treatment was inferior to terlipressin in reversing HRS-AKI. Therefore, octreotide and the midodrine should be used only temporarily for 24 to 48 hours and only if terlipressin is unavailable or contraindicated. Now, the next line of treatment is the transjugular intrahepatic portosystemic shunt. The important therapeutic option in patients with the portal hypertension is the placement of transjugular intrahepatic portosystemic shunt that may improve kidney function by redistributing blood volume and reducing portal pressure. There is currently insufficient evidence to recommended tips for HRS. Now, the next comes the renal replacement therapy. Renal replacement therapy has been viewed as a bridge to renal transplantation, but renal replacement therapy for patients with HRS-AKI who are not candidate for renal transplantation has been controversial because of high mortality. So there is no evidence on when renal replacement therapy should be initiated in patients with cirrhosis and AKI. Therefore, in patients with the cirrhosis, the decision about when to initiate renal replacement therapy should be individualized on the basis of life-threatening indications that are refracted to the medical management, like hyperkalemia, acidosis, fluid overload, uremic complication, trajectory of the kidney function, and or the overall prognosis. Now, the next treatment of line is the liver transplantation. And guys, the liver transplantation is the treatment of choice in patients with the HRS-AKI. The simultaneous liver and the kidney transplantation is the potential therapeutic option for patients with the prolonged kidney dysfunction before liver transplantation. Now, in 2017, the Organ Procurement and the Transplantation Network set forth criteria for simultaneous liver and kidney transplantation on the basis of previous national guidelines. These criteria include factors such as prolonged duration of AKI dialysis and the presence of CKD. The organization also implement safety net policy that gave priority to the patient with the persistent severe kidney dysfunction after liver transplantation to receive kidney transplant within the first year. Now, the kidney biopsy may assist in establishing diagnosis and determining reversibility of the AKI dysfunction and the need for simultaneous liver and kidney transplantation. The predictors of the reversibility of the AKI after transplantation, such as biomarkers, are need to guide allocation of the kidney graft. Now, prevention. So, the development of the AKI is common, yet the severe complication in patients with cirrhosis. Therefore, it is imperative to recognize and manage events that may result in AKI, particularly in patients with ascites. So, the volume depletion should be prevented through careful use of diuretics with the goal of at least diabetes. Albumin infusion has also been shown to reduce incidence of AKI and decrease mortality in patients with a spontaneous bacterial peritonitis. However, in study involving patients with the infection other than spontaneous bacterial peritonitis, intravenous albumin did not prevent AKI and was actually associated with the increased incidence of the pulmonary edema. So the long-term use of the intravenous infusion weekly or every 2 weeks in outpatient setting has led to controversial results. In a randomized controlled trial involving hospitalized patients, an intravenous albumin infusion targeted at maintaining serum albumin level at approximately 3 gram per deciliter did not improve outcome, one of which was development of ACAN and was associated with increased incidence of the pulmonary edema. Therefore, long-term use of albumin in outpatient or inpatient setting is currently not recommended. Various medications such as NSAIDs and renin-angiotensin-aldosterone system blocker have direct nephrotoxic effect by impairing intrarenal blood flow. Some agents have direct renal tubular toxicity like radiocontrast dye, aminoglycoside, vancomycin, amphotericin B. Some drugs like beta-lactam antibiotic (PPI) cause allergic interstitial injury. Thus, kidney function should be closely monitored in patients with cirrhosis and ascites while they are receiving these medications. Data on the use of intravenous contrast material in these patients are lacking. Cautious use of intravenous contrast material is recommended, especially in patients with a eGFR less than 45 ml per minute per 1.75 meters. Now, the presentation with cirrhosis and AKI. So, this is a flow chart which is summarizing everything. So first, we should take proper history, carry proper physical examination, then consider the risk factor that may suggest the cause of AKI. Like it could be recent shock, fever, recent initiation of diuretics and diarrhea. Then review medication list for active or recent nephrotoxic exposure or IV contrast. Then immediately we should discontinue all the diuretics, NSAID, AC inhibitors, ARB, because all these drugs will cause the vasodilators. Then perform the diagnostic paracentesis to rule out SPP. And then perform the urinary tests like microscopic assessment of urinary sediment, fractional excretion of sodium, fractional excretion of urea, and NG. Then we can find then one by one we should exclude the cause of AKI, like renal hypoperfusion, which is the most common cause, and it can occur from hypovolemia, which results from diuretic, diarrhea, gastrointestinal bleeding, and the hepatorenal syndrome. Then, if the patient is hypovolemic, then we should carefully assess the volume status, which we can done by physical examination, focus examination, chest radiography, and echocardiography. If there is intravascular volume depletion, then kindly correct it with the crystalloid solution. And if it is a patient is not a volume depleted, then we can administer 25% of albumin, that is 1 gram per kg, that is less than 100 gram per day in divided dose. Then, after correcting this, measure serum creatinine after 24 hours. If serum creatinine decreases, then continue monitoring for the renal recovery. If serum creatinine is unchanged, or if in case if there is increase, then we should reassess the volume status. And the volume expansion with 25% of albumin in if no volume over. Then measure the serum creatinine level after an addition of 24 hours. Then again, if serum creatinine decreases, then continue monitoring for the renal recovery. Again, if it is unchanged or increased level, then reassess the cause for the intrinsic AKI and repeat the urinary test. Intrinsic and the repeat urinary test. So either it could be acute tubular necrosis or HRSK. If it is a acute tubular necrosis, then then there's administered diuretic and initiate the renal replacement therapy. If it is HRS-AKI, then initiate terlipressin plus albumin. Now, the next cause of the AKI is the intrinsic or the parenchymal kidney injury. So, in that, 18 is the most common cause, or acute interstitial nephritis, which occurred from the antibiotic NSAIDs and PPI. And it could be because of the glomerular disease, which occurred because of IgA nephropathy, MPGN, and the cryoglobulinuria. If it is ATN due to drugs, then the discontinue nephrotoxic drug. If it is anti-acute this interstitial nephritis due to drug, then again we can discontinue offending drug. Consider the kidney biopsy for the proper diagnosis and offer the specific treatment. If the AKI is because of the urinary obstruction, then rule out the urethral obstruction and the ureteral obstruction and determine the post-void residual volume and the renal ultrasound. Now the presentation of the suspected AKI, HRS-AKI. If we know it is a HRS-AKI, or if we rule out all the possible cause and still AKI is unexplained, then we can take it as HRS-AKI and we can start the treatment accordingly. First, we have to administer vasoconstrictor plus albumin, that is 20 to 25 gram per day, and then monitor for the side effect before each bolus administration for every 6 hours if administered by infusion, and discontinue if side effect present. And then we have to assess the volume status daily. Then we can administer here terlipressin. Terlipressin, according to the FDA label, administered 1 gram intravenously every 6 hours. According to the EASL guideline, administered 1 gram every 4 to 6 hours as IV bolus or continuous IV infusion as an initial dose of 2 mg per day. If terlipressin is contraindicated or not available, we can still use norepinephrine, which is administered in the dose of 0.5 to 3 mg per hour, and then titrate according to the map. Then, after for assessment of the response, we should measure the serum creatinine level on day 3 of the treatment, as per ESL guidelines, or day 4 of the treatment, as per FDA guidelines. So, if the serum creatinine levels are are above the baseline, so there will be the two possibility. Either the serum creatinine levels are above baseline and the serum creatinine levels are decreasing. If the serum creatinine level decreases, that is, if the decrease in the serum creatinine more than 30% of the baseline, then increase the dose of terlipressin to 2 mg 2 mg every 6 hours, and according to FDA label and as per ESL guideline, if serum creatinine level decrease by more than 25%, then increase the dose in stepwise manner to maximum of 20 mg. Then continue vasoconstrictor if HRS AKI is reverse, that is more than 2 hours apart, the serum creatinine level is less than or equal to 1.5 mg per day, 1.5 mg per dl. Then discontinue vasoconstrictor for the then we can discontinue vasoconstrictor, And if the serum creatinine level is above the baseline level, then discontinue vasoconstrictor and evaluate for the renal replacement therapy. And we assess the development, the development for the complications like ischemic complication, respiratory failure, and volume. Now, this is the evidence of terlipressin plus albumin for the treatment of the type 1 hepatorenal failure, which is mentioned in the confirmed trial. The vasoconstrictor terlipressin is used for the type 1 HRS syndrome. So this is the phase 3 trial, which to confirm the efficacy and safety of the terlipressin plus albumin in HRS1. So the patients are randomly assigned in 2:1 ratio to receive the terlipressin or placebo for 14 days. In both groups, a concomitant use of the albumin was strongly recommended. The primary endpoint was reversal of HS, defined by the two consecutive serum creatinine measure of 1.5 mg per dl or less, at least 2 hours apart, and survival without renal replacement therapy for at least 10 days after completion of the treatment. So they have a total 300 patients they have included, and which was randomized to the 199 were assigned to terlipressin group and 101 to the placebo. So HRS reversal again was defined as serum creatinine level was 1.5 mg per deciliter or less in 14 days, was reported in 78 patients in terlipressin group, and the total number of patients was 199, and 18 patients in placebo group, and the total number of patients was where total number of patients was 101. So, and the reversal without renal replacement therapy by 30 days in 68 patients and 17 patients respectively. So, in the final conclusion of this is, in this trial involving adult with cirrhosis and HRS, this terlipressin and albumin for treatment of the type 1 hepatorenal renal syndrome was found to be effective than placebo. Thank you.